Good morning. Thank you for coming back, paying attention so quickly. We have a busy program and time to get going. What a terrific start we've had. We started with some traditional Swiss music, and we ended with calls to action from the Director General of the WHO, the European Commission, and our local friends here in Switzerland. And of course from IARC about some of the challenges we face. This first plenary of the conference can be on no more important topic about shaping the future, preventing cancer and NCDs, and advocating for commitments at the UN high-level meeting, which is coming up next year in New York. We have an action-packed 1 hour, and it's important that we set the scene up front. I mean, cancer and NCDs, we've just heard, you know, the numbers are going up. We know many are preventable. We need to work out how to bridge that gap between risk factors and good policy and develop how to achieve actionable commitments when the UN high-level meeting takes place next year. To begin the session, why don't we start with a short video?
We've all become very familiar with how infectious diseases like COVID-19 can spread, and as a result, our whole world has been upended. But there is another silent pandemic that has been unfolding in slow motion for decades: non-communicable diseases, or NCDs. These are diseases that can't be passed from person to person, and the chances are you know someone who has been impacted by them.
When you lose yourself to a particular illness that makes you lose touch to life, it becomes very difficult for you to cope.
Cancer, diabetes, heart disease, respiratory disease, and more all fall under the NCD umbrella. NCDs are the world's leading cause of premature death, disease, and disability. They cause 41 million deaths a year globally.
NCD, the non-communicable disease, takes more life than anything else.
It's estimated a quarter of the world's population are living with these chronic conditions. So what exactly causes NCDs? Some NCDs, like type 1 diabetes and some cancers, aren't preventable. But many are linked to the social and physical environment around us. Risk factors such as alcohol, smoking, unhealthy diet or lack of exercise, and poor air quality can all increase a person's chance of developing an NCD. And it's the world's poorest who bear the brunt, with 77% of NCD deaths in lower and middle income countries. So how do you tackle the problem? There are solutions that could save millions of lives lost to NCDs each year. Investing in NCDs and creating societies that promote health and well-being. Access to affordable, effective and responsive prevention, treatment and care services for people living with or at risk of NCDs. Strong leadership and community engagement leads to more action on NCDs and the underlying causes of inequality, which make people vulnerable to poor health. Voices at all levels, from grassroots to government, can play their part in creating healthier societies, where everyone has a healthy place to live, work, and play.
Thank you. Maybe a round of applause. I think the BBC Work Series, and that one, of course, was on NCDs, and it did set the scene for us. I also note that BBC Work Series have a session with the UICC, a series with the UICC. If you've got the minute, please do make your way to the chill zone, and you can actually start to view those videos throughout the course of the Congress. So we've had the scene set. Can we now perhaps welcome our first speaker, and that's Robert Yates from the London School of Hygiene and Tropical Medicine. Robert's no stranger to the UICC. He has joined us previously. He's going to have a talk with us today, about NCDs, about the policy and commercial decisions that might influence commitments we can make. Can you please make Robert welcome as he comes to the stage? Good to see you, mate.
Thanks, Jeff. Thank you. Thank you very much indeed, Jeff. Honourable Minister, distinguished guests, ladies and gentlemen. My name is Robert Yates. I'm a political health economist. And I want to take us in a slightly different direction, perhaps, in the next few moments, to really talk about the political approach to sort of getting the resources that we need to tackle cancer services, and also the political commitment. So this is very much sort of a team talk, a tactic talk, about the types of ways that we advocate for greater commitments to tackling cancer going forward. And hopefully that's going to work. Yeah. And really that is through the campaign for universal health coverage, recognizing that there is this great global momentum behind UHC, which is driving the global health agenda. High-level meetings in 2019, 2023. There was a special UN resolution specifically on universal health coverage in December 2012. We've got a UHC day. It's an SDG target in its own right. But perhaps most importantly, I think political leaders like and understand universal health coverage. They get it. And therefore, it's a very, very good brand to rally around. And dare I say it, I think it's perhaps more effective than some of the other things that we sell to politicians, but even things like primary care, health systems, dare I say it, even NCDs, that, you know, to some leaders, they don't really get what we're talking about. They do definitely get what UHC is about. And just to remind people what UHC is, this is a WHO definition. And it basically boils down to everyone on the planet getting the health services they need, the good quality health services they need, with financial protection, that you're not impoverished by accessing health services. And you'll see that we're not just talking about curative services, we're talking about the whole range of services, promotive, preventive, curative, rehabilitative, and palliative services too. Now, of course, you'll recognize that cancer services cover all those. You know, we are talking about right from promotion to palliative care today. So cancer services are fully integral to universal health coverage. And I just want to dwell on the financing and politics of this, because this is why UHC, and therefore advocating for UHC and cancer control, I think is inherently political. Because UHC, as you can see, if we're talking about no one at all being left behind, and health services being allocated to people's needs, and also it being financed according to your ability to pay, there is no other way of financing this apart from healthy, wealthy people subsidizing services for the sick and the poor. And the only way that can be achieved is through a predominantly publicly financed health system. So if we're serious about UHC, we really should be serious about increasing levels of domestic public financing and making sure that those resources are allocated as efficiently and equitably as possible, with the services going to the people who need them most. And this is an inherently political process. So our target for this advocacy should be ministers of finance and especially heads of government. I really want to emphasize that we should go for the top. And just to re-emphasize the importance of public financing, this is what Gro Harlem Brundtland, a big champion of cancer services, said at the high-level meeting back in 2019. You can only reach UHC through public financing. And of course, there is a very, very strong case for cancer services to be right in the heart of this campaign, because people requiring cancer services are high-need population groups. I mean, that, when we talk about preaching to the converted, I don't need to tell you that. And also because a lot of the services, particularly the curative services, are expensive, people have got a low ability to pay for them. And of course, we should emphasize that so many cancer services are extraordinarily cost-effective. We were hearing previously about HPV vaccines against cervical cancer. Really, really cheap, effective technology that should be available to everyone on the planet. So all these arguments argue for universal coverage of these services and therefore that they should be predominantly publicly financed. So what tactics should we employ to win over the Ministers of Finance and the heads of government? We need evidence and research, and this eminent audience, you'll be doing lots of that, producing absolutely fantastic evidence, but it's very, very important that this gets to the policymakers. We go beyond putting it in the medical journals to get it on the desks of the Ministers of Finance and also the heads of government. We need to agree coverage indicators, to hold politicians to account, to say it's just not right that only 30% of sort of children are vaccinated and that so many people are not getting the cancer services they need. We need to get political, and I know a lot of people find this a bit uncomfortable, but seriously, if you want the public financing, you just have to, and fight those injustices. And I would say that this is best done within the tent of the UHC campaign, rather than competing against other health priorities. If we can present a united front to the politicians, that's going to be the best tactics. And the way that you sell it, of course, is to promote the health benefits of this. I mean, that's self-evident. But being smart about the economic benefits, how it can stimulate growth, create employment, reduce inequalities, and also sort of environmental sort of factors too. But perhaps the best sell, and I know this sounds crushingly obvious, sell the political benefits. This is what your population wants, and if you do this, you will be popular, you will get elected. It's that straightforward. And we have very strong evidence that politicians like talking about cancer services. This was a previous Prime Minister in the UK, David Cameron, a party, the Conservatives, not known for being particularly pro-NHS, but very much putting his name out there saying we want to produce more drugs to tackle cancer. Other well-known political figures, this is Imran Khan, the former Prime Minister of Pakistan, whose mother died of cancer, huge campaigner for cancer services, very, very keen to bring universal health coverage to Pakistan. Obviously, Pakistani politics are sort of quite volatile at the moment, but you wouldn't rule out at some point that he might again try and make a pitch to become Prime Minister, and he will be the exact advocate. And perhaps the most obvious target at the moment, and some of you might not know this gentleman, this is Tim Walz, who is the vice presidential candidate for the Democrats. And I just found this online, that his personal experiences about a parent dying of cancer, how traumatic that was, but the fact that it plunged the family into poverty has shaped his political thinking. And so who knows, he might be the person to bring universal health coverage to the United States, and therefore someone to be really sort of talking to. So just to conclude, I think that what we're talking about is UHC is highly political, particularly introducing this equitable financing system. It's very popular, though, with politicians, and this is the card we should be playing. Cancer, in particular, is a highly emotive health issue, and I think is just the type of thing to provide inspiring politicians with the evidence that they want to do right by their population. So I think if we want to get greater political commitment, greater public financing in UHC, as well as maybe technical strategies, we need political strategies to get to the leaders who are going to bring this to the people. Thank you very much indeed. Thank you.
No, you're right. Thank you, Robert. Take care. Thank you very much, Robert, for that discussion on the political economy of health financing and service provision. And of course, it's important for us to hear, perhaps no more so than the tactics. And let's see if some of those get deployed later in the session and as we lead into the UN high-level meeting. Ladies and gentlemen, the format for the meeting, we've had a primer, we've had a video, we've heard from Robert about some of the realities when we're looking to fund and resource these types of activities. Now we'll have a panel discussion, which we will run for about 25-30 minutes. After that, there'll be an opportunity for you to participate through the app. So have that ready, because that will be fun and an opportunity for you to engage. And then we will have Katie Dane join us when we do a final wrap-up and a call to action as we march our way to the UN high-level meeting in New York next year. But for the moment, if you can, please join with me in welcoming our panel members. First up, who's already had a round of applause today, so let's give him a second one, His Excellency, the Minister of Health from Malaysia. Please, sir, come up to the stage. And while the Minister's making his way, Bente Mikkelsen, and this audience doesn't need much of an introduction. Bente, who heads up the NCD division at the WHO UHC Commission. Please come on up, Bente. Please, Minister. Take down the far end, sir. Thank you. Thanks, Bente. On the other end. See you soon. Now, Anna Gilmore. Oh, here comes Anna. Sorry, everyone's getting ready and they're on their go. Is the co-director of the Centre for 21st Century Policy. Please welcome Anna. Thank you. Please take a seat. Avril Power, the CEO of the Irish Cancer Society. Come on up, Avril. Good to see you. Thanks, Avril. Take a seat. And finally, and certainly last but not least, is Fabio Gomez, who's a regional advisor on nutrition and physical activity for PAHO. Please, Fabio, here he is. Thank you, Fabio. You take Fabio's down the end. Okay, panelists, thank you. We have got about a half an hour to discuss what is a very important topic. So let's try focus on the questions, keep it as brief as we can, but of course we need to make sure we understand this important topic. Minister, I'm going to throw to Bente first, but I'm just giving you a heads up. So when that freestyle Malaysian way, when Bente finishes, I might ask you to just reflect a bit on what we heard from Robert in terms of that political economy of health financing, and we'll start it out there. But Bente, to you first. As we head into this high-level meeting next year, and we're looking for actionable commitments, can you just reflect a little for us on what's happened since the last meeting, and where do we stand?
Thank you very much, and it's fabulous to be here. So many friends, colleagues, and we need you all. It's 52 weeks left for the high-level meeting. And if you don't do anything else this week, you have to think through what is the single or couple of paragraphs that you want to see in the political declaration that speaks to cancer. That's the most important thing. So I was also very inspired by Robert's speech, because I think this is the big shift since the last high-level meeting. For many years, the NCD community only spoke about international funding. And we have to continue to do that, of course. We want to continue to get support from the Global Fund, which we have now achieved for cervical cancer and HIV. And we are now super happy to work closely with the World Bank, who was actually the one pledging the most for cervical cancer. 400 million was committed, US dollars that is, in the Cartagena meeting, the first global forum for cervical cancer. So it's great, we need to have the international funding, but we really need to make cancer part of the universal healthcare agenda. And we recently published a study which shows that only 28% of the countries actually has included cancer into universal health coverage. That's very bad, guys. That's very bad. And it has to change, because unless we have a domestic funding, we will continue to have out-of-pocket payment, and we see that this drives poverty. And we also know that NCDs and cancer are driven by poverty. So if we really want to change this, we need to look, as you said, Robert, into UHC. I'm not sure if it's sexy enough with UHC. I hope you're right. I think we need to explain it more like the beautiful video. Thank you so much, Katie, for producing these things. It's fabulous. So one thing that has happened since the last meeting is the focus on UHC, domestic financing, a very strong collaboration. We just had a recent meeting on sustainable funding for NCD and mental health in New York. The other thing that is very important to be aware of is that cancer was one of the really forgotten issues in NCD and humanitarian crisis. So I'm very proud, and thank you to the government of Denmark, that we were able to have a global meeting on NCD and humanitarian settings. We had a side event on cancer. We have people here in the audience being part of publishing a manifesto for cancer and humanitarian. It's not complicated, or at least we cannot accuse the situation for being too complicated. We need to step up. We need to also look again on the NCD emergency kit, palliative care, and so forth. The last thing is really the vulnerability, and I think we will touch on it a lot, so I will stop there because I see you want me to stop. And that we did through addressing the small island development countries, because unfortunately they are at the forefront on the environmental crisis. So it gave us an opportunity to speak to the best leaders in the world. Those countries have been leading the NCD agenda for years, and they know what they are speaking about. And we were able to address NCD mental health and environmental changes. And through that, we also had the chance to really address one of the growing concerns, namely on social determinants and commercial determinants of health, because there are probably no other countries that are so vulnerable. If I should add one more thing, our focus is on migration and on the displaced people as part of the humanitarian. I'll stop there and hope to come back.
Thank you for that answer. We do appreciate it. And you've picked up some, certainly, points of agreements with Robert, which is up front, and talking about social and commercial determinants of health. And Anna, we might come to you after we hear from the Minister, just to hear something about commercial determinants of health, because there's been a lot of talk about politics and commerce so much in this already in this talk about health. Minister, some reflections on politics and resourcing and commercial in making good health policy.
Right. Thanks again, Professor Jeff, Don, and panelists. I'm coming back as the minister for the second time. A hiatus of about 5 years. And honestly and truly, the greatest challenge on enhancing and delivering healthcare is essentially finance. And I place two main agenda for my transformation, for my health transformation this time around. I was 2018 for 22 months in that government, led by Dr. Mahathir. You may know him, a 99-year-old Prime Minister. And then for 22 months, I get down to doing my reforms. And it was all like in the back burner for the last 5 years. And I'm coming back full cycle to address it. Health finance transformation to me is the greatest challenge. Being an upper middle income economy, and predominantly a health system that is financed by tax base, as opposed to SHI or insurance base, is a great challenge to get ever more budgetary allocation for the health ministry. And I knew it all along that I've got to be. I told the Prime Minister, if you can't give me the resource, allow me to be resourceful and innovative. And soon as do I get to realize that this is a challenge. Public sector spends about as an upper middle income economy, you should be spending about 5 to 6% of your GDP. I think we have been underspending in the health sector. We are now only achieving there about 4.3 or 4.4. 2.3 contributed by the public sector, while 2.1 by the private sector. And I've been nudging the private sector to be spending and investing more. But more importantly, I do not expect, it's all about opportunity costs. You think that, health is the most important, but they have other sectors to be funded. So I would believe that as a tax-based health financing system, I have got to be moving into things like having a private health facilities within a public hospital. And that would be like full paying patient wing in a public hospital where you could actually generate incomes. And you must remember that every one of us suffers attrition rate of your specialists, even your nurses now going into the private sectors and everywhere else across the causeway to Singapore. Now, I would want to really believe that this time around when I come back, I would, as a Minister of Health, I'm not only becoming a strategic purchaser of services, but as well a provider. In this sense, I now could generate an SPV kind of thing, where it's part of MOH, where we could actually deliver a kind of a private wing where you could charge. You must understand, in our system, to see a doctor, you only pay 1 ringgit, which is only about 20 cents. And to see a specialist, you're paying about 5 ringgit, which is about $1. And that going forward is certainly not sustainable, right? So I particularly would want to innovate to get to have more funding where I could generate, where I could generate income from my private wing in my public sector, in my public health facilities, where I see there are excess capacities by way of MRI, by way of CT scan, by way of specialists who are willing to do more, so that they get to be paid more, and they are retained in our public sector. Besides, of course, I'm doing outsourcing, meaning now I have nephrology, cardiothoracic services, cardiology, and radio imaging and radiology and imaging, where I get to outsource. I can't be building more and more brick and mortars, so I get them to come and I get and engage the private sector, but be paid at our kind of cost.
So Minister, it's a combination. I think it's about health financing transformation,
right?
Innovative models,
yep,
and partnership in those models, public and private.
Public-private partnership is so very vital for us to, to get to something that and at the end of the day, you get to address the B40 group in your public hospital. Then you get to address your M40 through our kind of private wings,
yes,
where it's not as expensive as the private sectors though. And then the T20, you'll get to innovate through your what I call as PHI, the private health insurances.
Thank you, Minister.
Right.
Thank you for that. And for that, I mean, call to action about innovation, about transformation, and about partnerships.
Right.
We might turn, we'll hear from Anna about commercial determinants of health, and then perhaps a change of pace and talk to Fabio about, nutrition and physical activity, but about successful models that you've experienced after we hear from Anna about commercial determinants of health. We all know about social ones, and we're learning more and more about commercial ones. Please.
Okay. Can you hear me?
Yep.
Great. So the commercial determinants of health is really quite simple. It refers to the way that the commercial sector impacts on health. And of course, those impacts can be positive, the creation of jobs, new medicines, when they're affordable and accessible. But increasingly, those impacts have been negative, really reflecting changes in society, the shift from small companies to large corporations, the growth in privatization, the growth in trade and investment liberalization. And the primary issue for cancer and NCDs more broadly is that increasingly, what is causing disease and killing us is the products of commercial organizations and multinational corporations in particular. And simultaneously, the greatest barrier to preventing those deaths and disease is the practices of those corporations, because they have a vested interest in maintaining the status quo, in maintaining their sales and profits. So if we're going to improve health and prevent cancers, we really need to understand the commercial determinants of health. So maybe I can dig a tiny bit more. Let me dig into those two issues. Firstly, the products, and then the practices. So the scale of harm from commercial products is vast. If we just look at 4 products, tobacco, ultra-processed food, fossil fuels, and alcohol, those products alone cause somewhere between 19 and 33 million deaths each year. The details are in our Lancet series, which I've got a couple of copies of here you can fight for afterwards. So 19 million deaths a year, that's the equivalent of wiping out the population of Romania each year. 33 million, that's the equivalent of wiping out the population of Peru each year. Let me give you a comparator. COVID, over 4 years, caused 6.9 million deaths, yet look at the response to that. But year on year, it's between 19 and 33 million. That's between 1/3 and 2/3 of all global deaths, or between 40 and 80% of NCD deaths, okay? And that's only 4 products. It takes no account of the chemical industry, glyphosate, so on and so forth. And those deaths are largely preventable. So let's now look at the practices. The key issue is we're not making progress, not because we don't know the policies and the interventions that we need to prevent those diseases. We do know them. Bente and her colleagues have set those out in the report NCD Best Buys. That was first published in 2017, and yet progress has been incredibly slow. And in fact, the latest evidence shows that in policy areas involving those health-harming industries, policy progress is going backwards. Okay, and the key reason for that is that these corporations oppose those policies. They use a number of practices to do that, but in particular, they use their political practices and their scientific practices. We all know that for tobacco. We know the tobacco industry created misleading evidence. It hid the harms of its products. That led to decades of delay. It now creates misleading evidence to create confusion over the policies that we need to address tobacco harm. But we've recognized that for tobacco. We have what's called Article 5.3 in the Framework Convention, the Global Treaty on Tobacco Control. And that basically recognizes the vested interest between the tobacco industry and public health. And it requires governments to protect their policies from the tobacco industry. It really is about excluding them from the policy-making table. But the evidence is now unequivocal that all those other corporations engage in exactly those same practices, in exactly the same ways, and for exactly the same purposes. And yet we continue to work with them. It makes absolutely no sense. So as we move forward, we need to build on the evidence, not just the evidence of what policies work, but the evidence around conflicts of interest, and work to address those conflicts of interest. So I hope that's a quick enough summary.
That was a terrific summary. Okay. A little frightening in parts, but a terrific summary. I mean, are there tactics?
Yeah, I mean, their tactics are exactly the same, and we've written papers on this. Their tactics are so similar that we've now developed a taxonomy of their scientific practices, which we've called the Science for Profit model. And that covers numerous industries. We basically looked at the evidence on how corporations influence science. It covers all sorts of industries, including the pharmaceutical industry, I'm afraid to say. But on political practices, again, we've done work so far on the major unhealthy commodities, so for ultra-processed food, tobacco, alcohol, gambling. I've got a colleague now applying our taxonomy to the fossil fuel industry, but the evidence is they're engaging in the same practices. So we need to treat them in the same way. Really, they have, where there is a conflict of interest, they should not be at the policy-making table. If you're doing food policy, the food industry should not be there. If you're doing alcohol policy, the alcohol industry should not be there. It's not rocket science.
Yeah. Hey, look, thank you for that. We'll come back to some of that, I'm sure. We'll head to Fabio and hear a bit about, nutrition, physical activity, and perhaps some models that you've seen work or not in your experience? And then we might throw to Avril from the civil society aspect, and we'll get a perspective there about NCDs and particularly about approaching the UN high-level meeting. Fabio, over to you. Some observations, comments?
Thank you. Yeah, I think the first thing that countries in Latin America, particularly leading this agenda, have realized is that we cannot move forward if we're not regulating the products and the practice of ultra-processed products and other unhealthy commodities industries. So the same way that policies advanced in regulating the products and tobacco products and the practices of this industry, countries have also evolved policies in the region, learning from each other and bringing regulations to ultra-processed products. We know that right now and today, even in the general public and even within, let's say, the health professionals and the overall community, there's a clear understanding, for instance, that diet, physical activity, obesity are all linked to, let's say, diabetes or cardiovascular disease. But if we're speaking about specifically about cancer, there's still not that close social recognition. But I think that's one thing that is important to build in terms of how you bring that that group to the discussions as well. So what countries started to do in the region, and this was really, one of the countries that pioneered the first approach was Chile in bringing warning labels to products that were excessive in sugars and fats and sodium. But then we learned from their experiences what was working and what could be improved and expanded that in terms of what are other nutrients and how stricter we could be there. So we could capture and regulate the ultra-processed products that are really driving the consumption or unhealthy dietary patterns and all NCDs that are related to unhealthy diets in the region and worldwide. With that, we had, and this was important because when we're dealing with food and nutrition, it's not straightforward as it is right now, for instance, for tobacco products. There was a lot of confusions and a lot of discussion of what should be regulated and what it shouldn't be regulated, what we should be eating or not. And part of that confusion was also introduced by the corporations, which made us believe that everything that is edible is food, right? And we had to make that distinction, and bringing warnings to those products had allowed us to make that distinction and then apply other policies that were as cost-effective or even more cost-effective. And what we're doing now is also many countries in Latin America restricting the marketing of those products, restricting those products from being sold or advertised in schools, and also to ban the purchase of those products from public administration. Public administration cannot spend money on those products going to hospitals or going into any other program of the government. And lately we have experience from Colombia also applying taxation to products that are excessive in these nutrients that have these warnings. So you build a regulatory system that regulates the products in ways that you empower and you build the capacity of a population to reduce the consumption of those products. So it's those are not legislations that are regulating people, but rather regulating the corporations. And lastly, really, really important, if we look at the countries that haven't been able to make progress yet or are delayed in make that progress in our region, is really comes to the political corporate tactics that the companies, healthy commodities industry employ to avoid, delay, or impede those policies. So in other words, besides regulating the products, we need to be very careful about how we design the governance and how the policy process is designed in ways that we can protect that, as Anna was mentioning, from the interference of industry. Because unhealthy commodities industry, they will always try to come on board as part of the solution. And if we're not clear about the fact that they're causing the problem and they need to be regulated in terms of their products, practices, and policies, we will not make progress, and we will continue to challenge those trying to get around the equations to make and finance the health systems in ways, because it's just not closing the tab in a way that can resolve those equations in a meaningful and sustainable way, including from a financial and economic point of view, right?
Excellent. Fabio, thank you for that. And of course, you know, South America, PAHO is not just one country, obviously. I mean, the variation between countries, are there patterns when it comes to policy? And when you answer that, Avril, will come to you, but I might just go back to Anna, who is doing quite a bit of nodding in parts of that, just to comment on some of your things. But Fabio, first of all, the differences between countries, are there patterns? Are there particular arguments?
Yes. Most of South America has adopted these sort of policies, somehow regulating processed and ultra-processed products that are excessive in these nutrients, but also expanding to additives that are also known as to be markers of ultra-processed products causing the harms for health. We do have what we see in the region is that the first countries, they took more time to adopt those policies. And as we learn from those processes, and as we also evolved our guidance as WHO in the region, we also speed that time and shorten that time that took to build the policy. So for instance, the first policy that came out in Chile took almost 10 years for them to have the law in place, and products with the warnings, cartoon characters that you see in cereal boxes gone away. So this is how long it took. In Argentina was one of the last countries that managed to implement that, and you won't find any cartoon characters anymore in any of the box. It took them 2 years from the point that it started the discussion in the parliament to the point that the products were in the shelves with the warnings, without cartoon characters, and with no marketing and presence of these products in schools. So I guess the importance of learning that every policy is a result of a negotiation, that you have to learn from that and move from that point on. And although industry will try to get you back to discuss 10 years again, etc. So it's really important to, instead of repeating ourselves, to move forward and evolve these policies. And that's what, what we're trying to support the region in doing right now.
So hold the line, hold the line. And just quickly, Anna, before we go to Avril, is this the start of momentum? Are we seeing?
Yeah, I think what's happening in PAHO is really exciting. And I think that there's a few things that Fabio was saying that are absolutely essential to recognise. Firstly, voluntary measures don't work. Regulation is absolutely essential. Secondly, there is always going to be a fight with industry, and it's unacceptable that it takes 10 years to get policies in place. We've got a crisis with obesity, so we have to stand up to these corporations, and a key way to stand up to them is to have a tool like Article 5.3, because actually it reduces their power. It may not reduce their material power, but actually it reduces their other forms of power, because if they're not in the room, they can't influence you. They can't produce their misleading evidence. They can't produce their misinformation. So it's really important, if we're going to make progress, that we recognize those conflicts of interest and get them out of the room. And the other thing is we've touched a little bit in this session on public-private partnerships and multi-stakeholder initiatives. And in some areas, as we're hearing from the Minister, they do play a role. But the evidence on this is also really clear, that where there is a conflict of interest, multi-stakeholder initiatives don't work. So working with the food industry to design food policy does not work, okay? And we need to recognize that evidence and move on from there. So
hey, thank you very much. We'll hear from Avril from civil society. Then when we've heard from Avril, Minister, we might come back to you just for some tips on, what is good health policy and how we can sell it through to government, just to get some thoughts on that. But first, civil society, the Irish Cancer Society has been very active. Please, Avril, tell us some of your experience.
Yes, I think I want to touch particularly on alcohol labelling and how Ireland, which I think is a country for many, is synonymous with alcohol, has become the first country in the world to introduce comprehensive health warning labels on alcohol. And again, I think that cultural context is really important, and I was struck by what Anna said in terms of health claims. So for many of you, when you think of Ireland, often people think of Guinness, which is a very strong Irish brand. The Guinness Storehouse is the most popular tourist attraction. It's where people head when they go to Ireland. And for years, Guinness was marketed in Ireland and across the world with the slogan, "Guinness is good for you." Was their marketing slogan. And in fact, we used to, after people donated blood, we used to give them a pint of Guinness to replenish their iron levels after donating. So that's how entwined alcohol is in Ireland, and also the kind of misperceptions that have been there for a long time about health. And while over recent decades there's certainly been growing public awareness about the link between alcohol and road deaths, alcohol and violence, including domestic violence, awareness of the health harms is still very low. And that's where I guess the Irish Cancer Society and our partners came in, because as the WHO has made clear, there's no safe, from a health point of view, there's no safe level of alcohol. Every drink does damage to your health. And from a cancer perspective, alcohol is known to cause 7 different types of cancers. But when we did research, and our health authorities did research to ask people about their awareness of that, over 70% of people had no idea. They think of liver cancer and liver disease specifically in terms of drinking, but no idea the link between alcohol and breast cancer, alcohol and bowel cancer, head and neck cancers. So that's why we've been pushing for over 10 years as well to get alcohol labelling. And I think the role of civil society in delivering that was really, really important, both in educating the public and politicians about the health harms associated with alcohol, in building support and maintaining support for labelling, and in countering industry's claims and the pressure, and we have a very, very powerful alcohol lobby, the pressure that industry put on politicians to back down. So together, how we campaigned was we used traditional media and social media to make people aware of the harms. We were part of an alliance called the Alcohol Health Alliance, which included over 60 different organizations, so reflecting the extent of alcohol-related harms. So cancer, the Irish Heart Foundation, variety of groups representing doctors and other healthcare professionals, people representing children and young people's groups in relation to marketing to young people of alcohol. So collectively, we had a very strong voice in making people aware of the risks. We engaged with politicians to build cross-party support, which I think was crucial, because we ended up with support not just from government, but all opposition parties. And we helped those politicians to fight back when they were getting criticism, both nationally and locally from the alcohol industry. We gave them the facts and we stood by their side to help them to fight back against industry. And I think another reason why civil society is so important in all of these things is that people trust us. The Irish Cancer Society is fortunate to be the most trusted charity. We're the #1 most trusted of all charities in Ireland, so that was really significant because people listen to us. And when you're asking people, well, do you want to, when you're hearing these, contradictory arguments, I'll often say on media, well, look, you have a choice. You can listen to the Irish Cancer Society, you can listen to doctors, you can listen to the World Health Organization, or you can listen to the spokesperson for whatever alcohol company is on the program with you. And I think that's really important. So, the upshot is that it took us 10 years. As I said, it took to get both support within Ireland and to get it through the international bodies. So 13 other EU member states objected to the European Commission, so we had to file, when you're within the EU, when you're bringing in a measure that could potentially cause trade barriers, you have to notify the EU Commission and give them an opportunity to object. And 13 countries objected within the EU, but the European Commission didn't accept those objections. They said the measure was proportionate. So finally then, in May of last year, May 2023, we got it across the line, and all alcohol now sold in Ireland will have to include labels that warn of pregnancy, of liver disease, of cancer, that include the alcohol content, that include the calorie content. So I know other countries have some of those, but it's very comprehensive in terms of what's covered. And I think that will really help, because as we always say in the Irish Cancer Society, knowledge is power. And if you don't have the knowledge, you can't make smart choices to benefit your health and reduce your cancer risk. So we're really proud now that as part of the work that we've done with all of our partners across civil society, Irish people will have the knowledge and the power to reduce their cancer risk from it won't come in until 2026 because they've given industry time to prepare for it. But from then on, people will have the knowledge and they'll be able to reduce the risk of cancer from alcohol.
Thank you. Yes, Tony, well done. I heard, we heard a few things there. Certainly there's patience. I know Anna will be thinking another 10 years. But about patience, about pressure, you know, and you spoke about pressure and about trust, and I think all of those are key. We are running very short of time. What I would like to do is quickly ask Minna for a brief comment about, you know, selling good health policy, and then maybe to the other four panellists, a single take-home message. You've got a minute to think it through. Leading into the UN high-level meeting, a single take-home message. You can only have a sentence. A single take-home message to our participants today. And you need to use punctuation, Anna. It can't be one sentence. But while you're thinking about that, Minister, good health policy, what does it look like?
Right. I think it's so very important to impress on your Prime Minister, the head of state and the cabinet members that health is a moral, social, and political imperative. Failing to deliver the demands of health, any government of the day will be shown the door, the exit door in the next general election. And it's so very important, Prof. Jeff, that we have shifted from the pandemic on infectious disease, namely SARS-CoV-2 of late, to what is even more onerous, and that is the pandemic of NCDs. I think I'm preaching to the preacher here. And in our last the National Health Mobility Survey that we have done in 2023, 4 matrices pinpoint that we cannot, sit back, because this is really the challenge. 1 in 3 hypertensive, 1 in 4 hypercholesterolemia, 1 in 6 diabetes, and 1 in 2, 54% to be exact, is either overweight or obese. That is a fact for the greatest killer in Malaysia for premature death is IHD, 18%, and of course, with that, CVAs, cancer, and what follows through. So with that scenario, I have to impress on the cabinet members that money should be placed. We will always be firefighting. We will always be in crisis of managing NCDs if we go to the curative hospital-based patient care. We just got to shift into one that is truly health care and emphasizing on the importance of really transforming our primary health care. And that is really truly health care. Either way, if not, we will always be on this sick care. So money that I've asked for is to address NCDs. And among the policies that I've managed to get funding for is actually war on sugar. Besides, of course, smoking, tobacco, whatever. But war on sugar, where I get to have the SSB tax, which is the sugar-sweetened beverages tax, an increase of it, and then hopefully to earmark of the revenue to actually addressing NCDs. Then, of course, they got to really believe in me to make to address this because the NCDs is really costing. Let me just say this very quickly. Please. The burden of disease is almost like total NCDs is 15 billion USD. It's almost like 4.3% of our GDP. And that is really not sustainable going forward. So I have got to impress that good policies has to be premised on addressing the NCDs notwithstanding the importance of, the infectious disease, whatever. And the emphasis is again to be more on screening, preventive, promotive, wellness, notwithstanding as well the importance of giving funding for our hospital, brick and mortars, of whatever. So good policies, have to be premised on addressing the pandemic of NCDs. And I told them that this is not a cost center. This is in fact a profit center that will ensure our workforce would be productive, that you get to really have a healthy citizenry that can serve to propel the economic growth of the country.
Thank you, Minister. That's good advice. And it is not a cost center. That's the way you've got to work it.
I get it. The mantra is that it is not a cost center. Stop thinking of us as a cost center. We are truly the profit center.
We're a profit center.
Yeah. That's how I preach that.
A health center. Okay, very briefly, we'll start with Fabio. One sentence, take-home message. Away you go.
Fight unhealthy commodities industries with regulatory policies that can reduce the demand and offer of their products. Thank you.
Well said. Avril, take-home message.
That people deserve to know the facts of how all products affect their health, and that there's a responsibility on governments and on multinational institutions to ensure that they're not misled by commercial advertising and marketing.
Thank you. Anna, yes. Anna.
That addressing the commercial determinants of health is essential to preventing cancers and preventing NCDs more widely, and to ensuring that our healthcare systems will be sustainable. So I urge all of you to get the commercial determinants of health on the prevention agenda, on the cancer agenda. And a key way to help address those is to exclude those health-harming industries from the policy-making table.
Thank you, Anna. Bente, final comment.
So to turn political commitments to action, we need to act on knowledge like tobacco, increasing BMI and hypertension. And we need to build on the power of success, like we have seen in decreasing tobacco figures despite the problem. And I would use the example of cervical cancer. Research and innovation led us to have now single dose, self-testing, we have new technology for leap invention, we have new partnership, and the last is the power of partnership, and I would like to especially address the possibility to co-create with the people with lived experience, and of course, Carrie, to continue this fantastic collaboration with UICC.
Well said, thank you.
Can I have my last sentence as well?
Your Excellency, of course.
As long as the most vulnerable and exposed to all form of insult, smoking, environmental, industrial, even infectious, pathogenic organism, we as Malaysia team, we would like to, truly advocate the Lung Health Initiative program as a comprehensive integrated effort to ensure that we will be, among other things, be able to address effectively the NCDs, one of it. Thank you.
Thank you, Minister. Ladies and gentlemen, a round of applause for the panel. Please, you can take some. Thank you. Take care. Thank you. Now, ladies and gentlemen, there'll be a scrum later on. Thank you. Okay, ladies and gentlemen, we have one more bit before we finish the session. Up on the screen, we have one last section, please. If you could take a seat. Ladies and gentlemen, Katie Dane. Katie, could you come up for us, please? Celine, have we got the app? Come on up, Katie. I'm looking for Celine. Okay, take a seat. Ladies and gentlemen, we're in the final section of this section. We'll be finished briefly. If you wouldn't mind just taking a seat. what we've asked you to do is to open the conference app and actually select a word that you think should be included in the submissions to the United Nations high-level meeting on NCDs. Katie, we've got a bit of a word cloud starting to appear up there. Ladies and gentlemen, can I ask you to join with me in welcoming Katie Dane, who's as you know, the CEO of the NCDA Alliance. Give Katie a round of applause. Katie, we've got a word cloud there about things we should address. I mean, are there things in there that are of interest to you that strike a chord?
Thanks, Jeff, and thanks to all the fantastic panellists just there in terms of setting the scene for the high-level meeting next year, as well as sharing some of the kind of key priorities that we want to see come out of that high-level meeting and some of the tactics that we need to really harness, going to Rob Yates's presentation at the beginning. If I may, Jeff, I mean,
Please.
I think I would like to kind of just share a few remarks building upon what we've just heard in terms of the scene setting for that high-level meeting. I mean, the first thing to say is perhaps some of you in the room are thinking a little bit skeptically about high-level meetings, perhaps sitting there thinking, oh, it's another New York meeting. You know, it's going to be another whiffly-waffly conversation that doesn't actually end in anything concrete and tangible. We've been through quite a few high-level meetings over the years in NCDs and the NCD Alliance, and I would say that these are a real opportunity for the cancer and NCD community. It's an opportunity because it really puts our issue in the spotlight. We're in the sun for the next 12 months, and we've got to make the most of it at the national level, regional level, international level. Secondly, these high-level meetings are the only time when cancer and NCDs go to the highest political level. It's heads of government, it's heads of state. And that's really critical given that these are whole of society, whole sector issues. And then thirdly, I would say it's critical because obviously these end with declarations, political commitments that all of our governments are then held accountable to. So I would really encourage everybody in the room to focus on the high-level meeting next year, to come together and strategize and really make this a successful high-level meeting for the fourth time.
Katie, thanks for that, and thanks for your commentary there. So are there any particular tactics or any particular things that people in the room and member organisations can and should be doing to take greatest advantage of this opportunity?
I think the first thing is that we've learned over the years that we have to work together and we have to sing from the same song sheet. At the end of the day, if the diabetes community over there, cancer community, cardiovascular community, mental health are over there, all pushing on different priorities, we're not going to get what we want out of it. So my first suggestion of tactics is that we've got to really unite around common messages. I think the second thing is what Rob was saying at the beginning about this being a really political process. You know, UHC is a political issue, cancer is a political issue, NCDs are inherently political, and high-level meetings are political. So we've got to really adopt political strategies to make sure that cancer and NCDs are heard at the highest political level. And if I may, in terms of kind of reflecting on some of the points that we're seeing there and also sharing what the NCD Alliance is putting out there as our priorities for the high-level meeting, which UICC and I hope many of you in this room will really unite behind. You know, this high-level meeting has got to be number one about leadership and accelerating implementation at the country level, because that's been the biggest gap that we've seen over the last 7 years since the last high-level meeting and even beyond that. It's got to be about implementing what we know works, and we heard a lot from the panel just now about those cost-effective public health policies and health system interventions that will make a difference for cancer and NCDs. The second one, which is very much in big lights on the screen there, is about financing. This has been one of the biggest Achilles heel of the cancer response and the NCD response overall. So this high-level meeting has really got to move the needle on financing. It's got to put sustainable financing on the agenda. And what that means, as we heard earlier, is domestic resource mobilization, health taxes being such a critical win-win intervention that governments can and should implement, as well as, obviously, public-private partnerships and innovative financing. Number three, and again, it really builds upon what you heard in that plenary, is this high-level meeting has really got to break down the silos. We're all working in our little silos in global health, in sustainable development. And as Bente mentioned in her remarks, there's been a lot of progress over the last 7 years of making common cause between cancer and NCDs and the humanitarian agenda, universal health coverage, pandemics being such a hot topic at the moment. So this high-level meeting can really kind of concretize some of those discussions that we've been having about the connections between NCDs and other parts of sustainable development. The fourth priority is, and it builds upon one of the remarks just now as well, is about community engagement. Again, over the last 7 years, we've seen really strong progress globally with WHO, as well as governments, of really kind of strengthening what we mean by meaningful involvement of people living with NCDs, people living with cancer, involving them in policy development, health service interventions, monitoring and accountability across the board. And so this high-level meeting has really got to kind of strengthen those commitments around community engagement. And the last one I would say is that this high-level meeting has got to be about accountability. The 2025 high-level meeting is an interesting one because it really marks the end date of the current global NCD targets that WHO set back in 2012 that many of us were involved in. You know, we need to see new targets coming out with a much longer time horizon. Let's look to 2050 in terms of the outcomes that we want to see, in terms of the implementation of policies that we know work, and really strengthening the role that civil society can play in accountability as well. And my last thing would be to say that in NCD Alliance, we've got this excellent online open letter called the Call to Lead. Currently, it's got over 200 organisations, including UICC, that have signed on. I would really encourage everyone, as a really simple thing to do during this World Cancer Congress, is sign on to the Call to Lead and take action in the lead up to the high-level meeting.
Hear, hear. Katie, thank you for that. Yes, round of applause. And for that call to action, because that is what we do need to do. We need to line up and get behind this and take some action, make sure it's not insular and siloed, but collective. Katie, thank you for that. Thank you for those tips and tactics. And of course, the word cloud now, you know, the single biggest numbers in equity, you know, health financing and prevention. Friends and colleagues, ladies and gentlemen, thank you for your participation in this session. If you're interested in how you can help and how you can get even more engaged, talk to Katie or the UICC team. You know, the URL high-level meeting is an important sort of point in time. Let's not waste the opportunity to maximise outputs. Thank you for your time. I hope you've enjoyed the session. Continue the conversation. Enjoy the Congress. Thank you very much. Thanks, Katie. They thought...